This conference will now be recorded.
My name is Garrett Huxall. I'm live in Tulsa, Oklahoma, and I'm a pharmacist with Farm Care Oklahoma. I'm going to hit a few highlights of what we're doing as pharmacists. And we tested Z and we tested myself, and Z doesn't have COVID and isn't making any IgG. I am negative for COVID, but I am making IgG. I've had COVID and had the vaccine. So have you guys had the vaccine? Okay, great. Did you get the Moderna or the Pfizer? I think the Pfizer gives us a little broader protection. So um, okay, I don't have any disclosures. And then one of the things that we consultant pharmacists, we used to be in nursing homes and long-term care and assisted livings and MRMI homes, and that was basically what we did. But in since 2017, more of the pharmacists that are board certified geriatrics are going to work in hospitals. And that's been a good thing for us because when they discharge them, meds are being reviewed and we're not seeing as many large doses that we could manage with a different product. Uh, Home health agencies, pharmacists also work with hospice care. We did a correctional institution. I don't know how, it's the weirdest thing is you bring those meds in and that door shuts. It's just a weird feeling. Okay. This is kind of what a pharmacist does, and we review the meds for older individuals, making sure they're on the smallest dose, no duplicate therapy. Do you have any idea how many meds an average person comes in the nursing home on?
12.
Right. 12 different meds. Some of the meds are being given by the orthopedic surgeon when they broke a leg 14 years ago, and they're still taking it. And so those we can probably get rid of. And then we look at patient-centered care. So we get rid of the meds that they don't use. We make sure they're on the lowest dose possible, and we monitor. And some of the things that we do on a daily basis, we're involved in aspects of delivery. We watch a med pass. We monitor the med aids. We manage the therapy, and we send, you get these little notes that say, can we reduce the Abilify to 5 milligrams on Mrs. Jones. Medication regimen review, just making sure that whoever is taking the meds, that we give the least amount possible. I keep saying that because a lot of times Norvasc came out probably 20 years ago, and Pfizer did a real good job. They said, okay, if you take 20 milligrams, that's going to cover 90% of the population, will control their blood pressure. We found out that 20 milligrams is way too much for somebody over 50. So 10 is the one we want it to be 10. And so we look for those kind of things. Chronic disease states, what's one of the big ones that we deal with?
COPD, CHF.
COPD, Oklahoma diabetes, 1 in 3. And those uncontrolled diabetes in the 1 in 3 is probably 2 of those 3 are uncontrolled, truly uncontrolled. We talk to the patient or the caregiver about counseling. This has brought up something new with marijuana. We can use marijuana in the facility, but you just can't have your CMAs or nurses giving it. It has to be, the person has to be okayed by the nursing staff that they're okay and can give self-administer meds. And then we put it in their room, put it in a lockbox. They're the only one that has a key. And that works sometimes. We have, I give you an example. This is a gentleman is in, I think he's 38 or 39, and his mother brings in a brownie morning and evening. And they put a bib on him. He's quadriplegic, and his mother feeds him this brownie. Well, she has to leave, and so we've had problems with people going in and getting the bib and eating the brownie off the bib. So don't ever underestimate what's going on. We've also had a lady that was in her 70s, and she assured me she knew what pot was and how to use it. So she had the gummies, anyway, I don't know what strength they were or anything like that, but she was chewing one of those at night to sleep with. And then she had the real THC lotion that she was putting on. Well, we had some problems with falls. So we decreased the amount on the gummy, and we still were having trouble with the falls because it seemed like she just used more of the lotion to put on. So anyway, we had to get rid of one or the other. And the hardest thing was we had to get the son involved to come in and tell his mom, pick one, you can have one, you can't have them both. So we'll be dealing with that. And if marijuana goes to a Schedule 2, where it's a Schedule 1 now that the U.S. government says it has no medical use at all, it can only be abused. And nobody wants to deal with that because of our funding is Medicaid and Medicare, and we're not sure what would happen. We look at therapeutic drug monitoring if they're on digoxin, that they have a potassium and a good serum DIG. They're on 0.125 on DIG. Any drugs that you can take pretty much can cause a fall, so we look at those, make sure that the ones that if we have to have them, they're causing falls, we can give at bedtime. Formulary management's a huge thing. Everybody has a formulary, and for example, Mucinex 600 milligrams twice a day is about $40 a month. The generic, which comes in 400 milligrams, and you take 2 of those twice a day, is $3. So when you do something like that, Medicaid folks, you can save a little bit of money, and maybe if they need something, you have some money for that. We do in-services. We cover anything. Now the big thing is with as an infection preventionist. Are you guys all familiar with that? Mm-hmm. So that's a real hard job, and you have to take a test, and then you have to turn in, like this morning before I got up here, that you have to go in and log in to the state website and say whether you're tested or not, and how many you were positive, how many were negative, total tests, how many you could do. And you just have to fill out some forms, but you have to do it every day. And as an infection preventionist, are we using the right antibiotics for the lung? If you have COPD, are we treating that properly, or are we just using a broad spectrum? And that kind of rolls back to the antibiotic stewardship. So if you have COPD and we're using Cipro, that's not a good. It's an effective drug, but that's not one we want to use. Antibiotic stewardship is one of those things that's coming to the forefront. Are you guys familiar with the 4 things that we get on a quarterly basis? They judge us on UTIs, falls, antibiotic stewardship, and weight loss. And if you stay below the national average, then there's money that's divided up between the homes. And like our is a 40-bed home, and we get the four. We hit all four of those, and so we got. I think it was like $16,000. And like the homes that don't make the money or get one, the other money goes into a pot that the ones that got the four. So you could. Sometimes it's a lot more. It's kind of it's a game. It's fun. We help with quality assurance measures, and we medication use and evaluations and immunizations now. Uh, Medicare says that if you have had the 23 valent pneumovax in a year, then you can have Prevnar 13, and they'll pay for both. You can have the shingles vaccine, Medicare will pay for that. You can have the Tdap vaccine and the flu vaccine. If you're over 65, I'd really suggest that you do the double strength flu vaccine. We've had some good results with it. Do your homes all do the vaccine? You can run the super bill and it'll tell you what the Medicare is paid for so that you can pick the other one so that you can get paid. Consultant pharmacists came back in the George Archibald in the 1960s was working in a hospital in the nursing hospital, and they sent him over to the nursing home. And anyway, that was where the term consultant pharmacist came from. We're getting, if you're board certified, it's a test, and we were kind of talking about this because it was kind of intimidating to take the test. Like you walk in the room, you get 2 pencils and a pad of paper and a calculator. You take all your rings, your watches, everything out of your pocket, and you put it in a tray, and they lock it up, I guess. But then if you have to go to the restroom, you have to hold your hand. I had more problems with the protocol than I did, I think, with the test. But there are more and more pharmacists are getting board certified. It's one of the things that we can use, and the geriatrics is one of the things that like insurance company, community care is looking for to review claims. A fellow of the American Society of Consultant Pharmacists, that's kind of the fellowship lasts about a year. There's certain things you have to meet and go through, and you have to have a paper and you have to defend it. So that's what a fellowship is. You guys familiar with the Beers criteria? Get real familiar with this. A guy named Daniel Beers was a physician, and he wrote 50 meds that he thought seniors shouldn't be taking. And anyway, it kind of caught on. Medicare took a look at it. And so what happened was, like Elavil is on there. There's some of the other antidepressants are on there. But if they're on this list, this could get you in trouble because now this has become kind of a dispensing or a prescribing criteria. Is it on the Beers list? We don't use it. And the Beers list usually says it's, due to falls or something like that, but it'll tell you. This has probably been one of the biggest things that has happened to long-term care pharmacy. Gave us some guidelines and gave us some information and something that we could also go back and tell the physician, hey, this is on the Beers list, and we switch it to something else. Now, if it's on the Beers list, and that's if you're using Elavil for pain or amitriptyline for pain, as long as you document it, we're okay. This is a new law that has just passed. It's the Smalley law. And I know you can't read that, but I'll tell you what it means. The Smalley law now says before, if I sent you Rocephin and lidocaine out for your patient, I had to have a RN mix it up and give it. Which, if you come to the pharmacy and we're mixing bags, we'll have a tech doing that. So the Smalley law says any licensed personnel. So you can have an RN do it, and it gives the LPNs now a chance, or they can do that. And most of those can do that anyway. They just haven't been able to do it in long-term care. And that could be in effect, I think, for 2001 or something like that. Okay, we'll talk a little bit about medical marijuana. You guys, this is going to be a bigger issue than what we normally thought in long-term care. February 1, 2019, 33 states in the District of Columbia legalized medical marijuana. 10 states in the District of Columbia legalized recreational marijuana. Oklahoma has a petition before the Senate or the House now to have recreational marijuana. As I said, marijuana is a Schedule I drug, which the government says it has no medical use. And as long as it's Schedule I, I don't think you'll see a whole lot of it in the facility because of our funding sources, the federal government with Medicare and Medicaid. I just don't think anybody will take a chance with that. It's still illegal, even if you have a card. You can't get a prescription for it. You can't buy it from a non-licensed dispenser or dispensary. You can't use it in the workplace. You can't transport it across lines. You can't smoke in public areas. And the biggest thing is, if you, like in the nursing homes, we have, you can't smoke within 25 feet of the door or something like that. That includes marijuana. You can't give it away. You can't buy with a credit card, and you shouldn't drive while impaired and possessing more than what's authorized. And Oklahoma is pretty generous in what we authorize. The risk management is storing the marijuana. If we store the marijuana in the facility, it's usually in the room and the patient has the key. We don't monitor it. We don't count it like we do bedside meds or anything like that. That's strictly between the family and the patient. And the patient has to be mentally able and physically capable of having a bedside med. The administration is by the family or by the person or the patient. It has to be care planned that we know it's in the room and here's what we're doing about it. We don't monitor it. We don't buy it for them. We don't bring it in. It's all taken care of by the family. One of the things that we've seen is in the scooters is they seem to be they drive a little faster if they've been chewing. They usually get the gummies, and if they've been chewing the gummies, driving the scooters, they seem to drive a little bit more quickly down the halls. And the other thing is, if you need in your policy and procedure that if somebody steals it, somebody walks in and just yanks the thing off the wall and walks out with it, which we've had happen. The theft potential, you're not responsible to replace it, that sort of thing. Any questions on that? Here's some best practices that we kind of come up over the years. Make the care plans, who has it, what they're doing with it, any adverse effects that you've seen with them, and who brings it in and how do they administer it. You have to develop some policies detailing where, if they're going to smoke it, where they can. We have one home that allows when they go out to smoke, they can go out and smoke a joint if they want to. If you have it in the building, then you have to have that as part of your admission package, that you inform the residents and families that you're admitting, and anybody that's already in there, that you have families that have marijuana. You have to have the policies and procedures just as the side effects are what to expect, how you tell somebody's had too much, that kind of thing. Those need to be all written down. And you have to have proof of the registration card. Now, you can have a copy of that and then give them their card so that they can go get it. And then you have to educate staff. The thing with the staff has been, we seem to be missing a little bit of it sometimes. You know, they'll give them the key and they don't want to get up or something. They'll give them the key and the staff will take a gummy. They'll give them a gummy. This is one of those things that's always seemed to be kind of we're always messing with that, it seems like. Okay, best practice is done. Permit staff to administer or store usable marijuana. Don't let them do that. And they can get a card. I think it's $25 that you can get a card that I can go get your marijuana for you. And you don't want to do that. You want to have whoever has the card or their family member to do that. You don't want, and that would be allow the staff to act as a primary designated caregiver to use the card. Or, we good?
Somebody's not muted.
Oh, okay. Permit residents to store the plants on the premises. The law says you can have 6 plants. Just make sure they're not on the premises growing in the garden. That's not good when the police come around. Marijuana, if they have a card, is not an ADA issue. And that's more for employees than it is for residents. Again, marijuana is considered a class 1, no medical use. You need a policy in the facility. You need to add it to your admission packet. Now, CBD oil, that doesn't contain THC. The state of Oklahoma said we're going to treat that as an OTC. So you can have it, we count it, we measure it. You know, here's how much in the bottle there was, here's how much they used, and we're okay with that. We've got a ruling. Rules, the Oklahoma State Department of Health has established the Oklahoma Marijuana Authority, and you can go to omma.ok.gov. What I found kind of interesting was there was other states that had already had marijuana on the books and were doing pretty well with, and they like Colorado and some of California. Oklahoma decided we were going to start from scratch. We were going to make our own laws. We were going to write whatever we thought was the most. And if you remember when they were writing this, the Board of Pharmacy lost its executive director over something. You know, she said if the person was the lawyer that was writing the laws, that she would include a pharmacist in that. You know, she could go to work for the Board of Pharmacy. I think it was in jest. But anyway, she lost her job over that. Considerations. You want to treat marijuana just like any other prescribed medication and monitor for, you want to monitor for abuse. If they're not, I mean, if they're just high and that's normal, that's okay. It's not FDA approved and there's no pharmacy or pharmacist involved. And we've seen, I've seen 2 of the cards that you go, and just like getting a regular marijuana card, but it's for a designee so that I can get your marijuana. I can go, you know, to a dispensary and buy whatever you want. Do not let your folks do that. I know it sounds like a good idea and all that sort of stuff. Don't let them do that, because if they come back from the dispensary and you know, if they bought 30 ounces or 20 ounces, and there's how you're going to weigh it when it comes in to know what it is. So you just don't want to do that. We've had one home did that for about 2 days, and we were short about 10 grams. Okay. A person, the new law in Oklahoma states that a person in the state is issued a license to consume marijuana legally, and you can have up to 3 ounces on your person, 6 mature plants, 6 seedling plants, 1 ounce of concentrated marijuana, 72 ounces of edible marijuana, and up to 8 ounces of marijuana in the residence. So that's what you can have. Now, I don't think you can have all of it, but you can have 1 or 2 of them. 3 ounces is quite a bit, and 72 ounces of edibles, that would be a lot. Drug testing will be affected if they have a card, they test positive for marijuana, it's no longer considered a positive. That's the basic thing that you have to remember here. Restrictions, it can still be, if your policy in your facility says you can't smoke marijuana, then whether they have a card or not, or whether they test positive or not, you can still enforce your policy of the nursing. Restrictions, I didn't know this, but all smokable, and they've got those things in vape, called vaporizers and e-cigarettes. They've got them in that, so you want to be sure and kind of monitor that. I've never been around does anybody know, do the vapes have, if you're smoking the or the oil or marijuana, whatever you're doing in those, does it smell like marijuana or does it smell like a vape? Any ideas?
They smell like marijuana.
It's a tinge of, like,
Yeah.
you're not really sure, but you
Yeah.
think that might be weed.
It's not like a normal nicotine vape smells like fruity kind of most of the time, but you can tell the difference in a marijuana.
Oh, okay.
Yeah, you can kind of, you get the hint of the marijuana smell.
Not as strong as smoking an American cigarette, like a joint. It's thick.
Okay, thank you. Anything that any time there's a restriction on imposed with a tobacco product, the same restriction will be imposed on any kind of smokable marijuana. Little is known about vaping and its side effects, and we know even less about the THC that they're putting it in there. They make it, they use propylene glycol, so it's more absorbed in the lungs. Propylene glycol is we would consider toxic if you were to ingest it. So that's what, I'm sure it's in a small amount, but that's one of the things you want to watch. And also, if they're vaping this, you want to make sure and watch them for COPD. You want to watch for lung infections. And now if they're smoking the vapes, we've only had luck with levothyrox or levoflurane or Levaquin, and it's in the 500 and 750 dose for 5 to 7 days if they're vaping and they have a lung infection. That's the only thing that we've seen that that works. Okay, let's talk a little bit about pharmacy and the things you do. Oklahoma is one of the few states that still have patients have the freedom of choice with caveats. As long as you can, if I can supply the meds like Remedy does, you could use our pharmacy. But if I can't supply the meds like Remedy does in the packaging and the carts and things like that, then you can exclude our pharmacy. So that's one of the things. And in Oklahoma, one of the things is that the medications are the patients. And we've had some trouble on skill wings when, I'll just give you this example. This family came to see their grandfather who was in a skilled side for a broken hip. And he had Lortab, and he had Xanax, and then he had his blood pressure meds, is antidepressants and things like that. Well, what do you think the kids wanted? They wanted the Xanax and the Lortabs. And so they kind of had a reputation. It was a smaller town. They had a reputation around town as, kind of enjoying those sort of things. So the nursing home didn't give those back. They kept those and were going to destroy it. They went to the state, filed a complaint. The state sent a surveyor out, and there's a 787, it's the number of the law, says that you have to give all of the skill medications to the patient as they're being discharged. And so they gave them the Xanax and Lortab. And little gentleman didn't get it, but anyway, they gave it to him and they got a deficiency for it. So that's one of those things you might want to consider. We were last year, the FDA was saying that the DEA needed to come in and make some guidelines for this. When the DEA went through Oklahoma and Texas, they said that you had to give the narcotics back to the closest relative. And we were shocked because, somebody has 180 OxyContin, no telling who the closest relative is. So we petitioned our board of pharmacy and they said we were going to ignore that law and we would go back to the 787. They've tabled it and the DEA has not come out with a written guidelines as of yet.
So you do give it to the family? Because I know we've had a couple of cases where we haven't, like, or not.
In my home, what I do is if we're sending them home and they've got a family member that we're aware of, I don't send it home. And then if they come back and ask for it, I'll give it to them.
Okay.
But if I thought they were going to give it to the resident, I'd send it home.
Oh, definitely, yeah.
And this is kind of the same thing where we practice. One of the things that we're doing now is giving immunizations. Walmart is, if you don't know, Walmart is going to do immunizations in all their stores. And I was talking to a Walmart pharmacist, and when we gave our vaccinations for the COVID, when we thought 85 people were going to show up, we had 35 residents, and we thought we'd have 50 of our employees show up. We had about 12 vaccines left. And I asked what they were going to do with it because I thought they were going to put it back in the ice chest or whatever and take it back. Well, they told me they had to throw them away. And so we called downtown and called the pharmacy and called the bank and said, hey, come down and get your vaccine. And the pharmacist with CVS was nice enough to put all those people on the list so that when we came back for the second vaccine, he had them covered too. That being said, the new hours at Walmart pharmacies are 9 to 7. So if you show up about 6:30 and they've got an open vial, they'll give it to you whether you've got an appointment or not. So it's one of those things, if somebody really wants to try to get in early, that might be something you want to consider. The Indian Health, I have a good friend that works there, and they give about 350 of these a day. And when they end up with like 4 or 5, they go over to Walmart and try to find somebody that looks like an Indian to give them a shot. I mean, they're not going to waste it. And I think we need to be doing that too. Choosing a consulting pharmacist. One of the things you want to do is probably talk to another nursing home and other nursing home administrators, see what the pros and cons. There's, no two consultants are alike. Maybe independent. I know one independent pharmacist now that's in Oklahoma, and most of us are part of a pharmacy services. They need to be personable, work well with staff, and that they come when you're having your state survey. We used to do that, and we were there for a couple of days with you guys on the survey. But what's happened is, as you know, the surveyors sit in the back room and they ask for a few things, and they don't let us help very much anymore. So we're always available to call, we'll drop by and that sort of thing, but they've kind of taken us out of the survey process. We're required to visit in long-term care every 30 days, in assisted livings every 90 days. And are you guys familiar with the new rules that are coming out with assisted livings on the antipsychotics? You're going to have to do pretty much the same thing you do in long-term care for the antipsychotic. It's passed the House and Senate. So you'll have to have a diagnosis. You'll have to have monitoring aims. You'll have to have behavior sheets, that kind of stuff. You have to have dosage reductions or trials. That should keep the facilities in compliance in state and federal regulations, help them with the policies and procedures updated, make sure the nursing home is compliant. We can save you some money, like with Mucinex, and we can work with you on your formulary to develop a formulary where everybody's on it. Like the homes that I go to, you pick Tylenol 325 or 500, but there's no use to have both. So let's just pick one and we'll go from there. It shouldn't cost you money, and it should save you a little bit of money, even if, you know, the way we bill out is by the day. And I think it's $600 maybe. And if I can't save you $600, I shouldn't be in there. Here's some more duties that we kind of outlined. We work with the CMAs or MATs on the med pass, and we go through the med cards and make sure everything's in date and everybody has all the meds that and that's stored correctly in there. We review the ordering procedure, and I think like in our homes, we have RX Link, and so we check that to make sure we verify what you ordered came in and check and make sure it's in the cart. We review the med sheets. We watch for patterns. Doses charted all at the same time. A particular nurse giving all the CDS meds. I'll give you an example of this because you'll deal with this whether you like it or not. We had a nurse that is about a 140 bed home, and they had a wing of more or less Alzheimer's patients that they shut off. And every night she would give every one of them a Lortab. Nobody else would do that. And so how do you think, how did we address that? Any ideas? We did a UA on the patients and they all came back clean. And so we knew she wasn't giving it to the patients. And then when we confronted her, she'd been doing this for 6 or 7 months. She wasn't taking the meds herself. She was giving them to her boyfriend. So I didn't understand that, but that's more common than what you think. Also, anything that's given routinely, you want to make sure that you have, if it's a pain medication, that we're logging in and addressing and monitoring the pain. See if we're doing a good job. Also, now, if they're on Oxycontin, morphine, something like that that's pretty routine, I like to keep Narcan in the building. And that way, if something happens, I like to keep 2. If something happens, I can give one, call 911. If I need to give another before they get there, I can do that, and then they're on their way. And believe it or not, we've used it a couple of times. If you want to kind of tune in to anything that if, they're charting and I'm hurting and I'm only hurting between 9:30 and 10 every morning and they're giving me a Lortab or they're giving me a Tramadol or an Oxycontin. Those are the kind of things you want to look at. And as an administrator, I would go look at those and I would have the CMA or the nurse, whoever was passing it, just explain it to me. I mean, I think that's a good thing. And the other thing is I would take the count sheets and I would pick one or two meds out of the count drawer and make sure they match up just on a routine basis. Just, I'm here on Monday, let's do it. And pick two and see what the counts are, see if they match up. It's a quick way to catch a problem. And if you catch it early, it's a lot easier to fix than if you're chasing, 6 months worth of. Expired meds and improper storage. If you remember the calcium that we were giving, the calcium that we were giving back in the nose, it had to be set up right. We would look at those. We would make sure there's no tape on the back of the cards. Make sure the tablets haven't disintegrated, that sort of thing. And auditing controlled substances. When we do that, have you guys ever watched your CMAs count out between shifts? It's hard. I mean, it's hard to keep up with them because, 15, 24 to 36, I mean, I don't think that fast. So I pull all of them out. I look and they don't like it, but I pull them and look at each one of those. And, 9 out of 10 times they're okay, but I still have to kind of slow them down to do that. And I can do that every now and then, maybe once a month. Destroying meds, you have to do that with the director of nursing, and meds can be donated to charitable pharmacies, no control meds. But now there's one in Oklahoma City, there's one in Tulsa County. In Tulsa County, I just got a little postcard in the mail. We've done $36 million since we started wholesale prices of recycling meds. Tulsa County has also said if you're on Lovenox, we get a lot of that. If doesn't matter what part of the state you're from, you can get Lovenox there for free. And if you were coming through Oklahoma and your child had a seizure or needed Dilantin or something like that, we have a way now that you can stop there and get that, and that costs nothing. I mean, absolutely nothing. This was one of the best things we've ever done. There's a push to have us recycle control meds, and I'm against that because I don't want to be responsible for taking those to the pharmacy. I don't want to be responsible for any of the counts or anything like that because they're just too much, too easy to lose a few of those on the transport. If you're reviewing a chart, we're going to look for duplicate therapy. Make sure you don't have furosemide and hydrochlorothiazide unless you're in kidney failure. Improper usage, if you can't swallow meds and you're having extended release and we're crushing it, then we go back and fix that for you. Meds that aren't being correctly given, maybe it's, supposed to run it in at 20 cc's an hour or something like that. We'll look at that. The dosage is inappropriate, too high or too low. Contraindicated meds, and you wouldn't think laxatives and antidiarrheals would be something that you would catch a lot of, but we'll see that they didn't stop the Imodium. It was ordered times 3 days or something like that, and it just kept going. We'll catch that every now and then. If they're allergic to a med or an adverse drug reaction, unless it's expensive medication, like if you're put on a pain med and it's an opioid, we always start a laxative with Silicon S because it has a stimulant laxative and a stool softener. One of the things you might, this was new to me. Our speech therapist came in, and all the folks that are on antihistamines for their allergies. I had 32 residents, and I had 28 of them on some sort of antihistamine for allergies. Our speech therapist came in and evaluated those, and 22 of them didn't need the antihistamine because it was a swallowing problem. So we DC'd the antihistamines, which DC'd the side effects of the antihistamines, but none of those folks are having any problems, and I had no idea. I mean, we did this probably a month ago, and I had no idea that you could do that with a speech therapist, so that might be something you want to talk with them about. We'll give you examples of and access to drug information, in-service education, computer-generated reports, lab testing, and medication delivery system. Okay, the medications belong to the patient. That's one of those things. Oh, I'm sorry, it's 847, not 747. But anyway, when they're in the admission package, if you're going to donate the meds, just add that to your admission packet, and then when they sign it, you're ready to go. Controlled substances or DON and a consultant. And if they pass away, you don't give the meds to the family. Unused meds. You can donate. Like I said, that's a great program, kind of expanding every day, and also they're getting new, we're covering more and more meds and more people. Do you guys recycle now? Anybody?
We donate ours.
Pardon?
We donate ours.
Oh, great. Okay, unused prescriptions must not be a controlled substance, must have 45, must exceed 45 days to allow redistribution. None of these can be resold and can only be donated to a licensed charitable pharmacy and must be kept under the control of a healthcare professional. That's kind of the rules. Let's think about your manifest contain the name of the consultant pharmacy, the name of the DON, the name of the nursing facility, and the receiving pharmacy. Name, strength, and expiration date of prescription drugs and number of dosage units of drug must be maintained by the nursing home for 2 years. Transportation is responsible of the receiving pharmacy. In Tulsa, we have retired physicians who pick those up for us and take them back. So that works pretty well. And if you need, I can give you Gina's number at Tulsa, and she'll send you forms that have all those things that you just have to fill in the blanks. You have to mark out the patient's name and dispensing pharmacy. And that, we just do that with a black magic marker real quick. And that's for HIPAA. And if you have any theft, diversion, it must be reported to the Oklahoma State Health Department and the Board of Pharmacy. If the patient is still alive and they take the meds or we lose them or whatever in this process, then it's resident abuse. Ordering prescriptions, most of that is automated now. I know we have a computer software that you just scan the barcodes on and it'll order it, tell you whether it's too soon, when you can order it. And if there's a dosage change, it gives you a place in there to do that. control prescriptions, the last session, control prescriptions can only be transmitted electronically. They have, each physician gets 2 books of 50, and there's special direct pads that they can write control prescriptions on, say, if they're, for whatever reason, they couldn't get to do it electronically. But I'd say 99% of the prescriptions we receive are for controlled or electronic. I've only seen one of those pads that we've actually, or one of those scripts that we've actually used. Here's the insurance companies that are playing more and more role in what we were able to do. And they say that nursing home employees, unless they filled out and they are an agent of the physician, where you can fill out the paperwork and they can call in prescriptions and things like that, your just regular RN, LPN can't call in the scripts. And a lot of these things that we're gonna see in the next year and a half are gonna be driven by the insurance companies, and they're trying to cut costs. So, and then the prior authorizations, if you guys run into those, I do 5 prior authorizations. You guys know what a prior authorization is? I do maybe 5 prior authorizations a week. Yesterday I did 7. And one was for Casodex which is used for prostate cancer. And he's been taking it for a year. You have to do another PA. It's really fun. I'm sure you guys know it. Now the emergency kits, do any of you have the kits where it has the computer box in the building? We have one that if you want Cipro, say 500, you need 2 of them. We've got a little box about this size that you've told us what you want in there. You call the pharmacy, and then we put it in the computer, bill it out to the correct patient, and then that little door opens and 2 Cipros come out in a single pack. Pretty slick deal. It's about $100 a month to have that. Otherwise, you can have a tackle box with meds in it. You can't have controls, but you have to have it. You have to have a written verification of what you're going to keep in your emergency meds. Used to be we could have a cardiac stimulant, didn't matter which one, respiratory stimulant, again, it didn't matter which one, and you could have Dilantin. They don't make injectable Dilantin anymore, and the Alphadantin that they did make, you can no longer get. So if you go by the old rules, you can only have a respiratory and a cardiac stimulant and Benadryl. You can't have any control meds, and then you have to keep the log of whatever you take out of the box for 2 years too. And then you guys have any questions? You guys have emergency boxes? Usually if you're within 15, 20 minutes of the pharmacy or downtown or something like that, it's kind of, we can get it there about as fast as you can get it out of the emergency box. Formulary guidelines must fall within the board guidelines. If, like, we ask that the physician sign off on a formulary switch, and then all the pharmacists that can do that are listed, and so they have to sign off, and then the board has to approve that. You got to have a policy and a procedure, and it does be given by a nurse, PA, or a doctor. Must notify pharmacy on access of the emergency kit, unless it's in a little computer deal, and then it automatically notifies. We let it out so we know about it, and then we bill it back. And if they got 2, we send out the remaining 8 the next day. It can only be restocked by a nurse or a pharmacy employee. Unfortunately, this is going to be a big issue for you. I probably go to 18 or 19 homes a month, and probably in an average month, I'll have 2 homes that we've got some sort of diversion going on. Diversion is illegal obtaining or distributing or otherwise legal prescription or controlled substance. Diversion can also be one of the things we found out. Some of these newer meds that are like Ernesto that you hear on TV all the time are $60 a cap. And so these patients or these employees, families get put on Ernesto, and all of a sudden we're missing our Ernesto. So those are things other than scheduled meds that we might look for. Who is diverting controlled substance? Anybody that has access to the key, even like if DC meds are locked up in the nurse's office, you want to have the nurse have the key and have the key on her. You don't want to have her put it in the desk where somebody else can have it or get in it. We've seen that happen. Anybody that has access to controlled substances is a possible diverter. You know, Billie Holiday was heroin. All of these folks had died of overdoses or drugs played a significant part in their deaths. Prince, one of the big things we're having is, if you can believe this, Amazon hasn't taken it, eBay did, but Amazon hasn't taken off the pill punches. There are single pill punches like that are labeled for OxyContin, so you can fill it up with talcum powder and fentanyl and punch it down and it looks like an OxyContin. That's what happened to Prince. They gave him 4 units of Narcan when he landed his plane before he came to the first time. That's a big problem. Believe it or not, fentanyl is not scheduled in China, and that's where 90% of the fentanyl comes from. In the state of Oklahoma, 69% of the drugs that are abused that we catch that are abused are pharmaceuticals, 31% are street. In Oklahoma, we have kind of a unique situation. The Mexican cartels are now making the methamphetamine, and they're making it in 50-gallon drums. The consistency is good. I mean, it's a consistent product. It's not, they know how it's going to work, how high they're going to get when they use it, and that sort of stuff. And they stabilize the price on some of this, so you don't see as much of them cooking and burning up a house and all that sort of stuff that we used to see. They've also done that with heroin. If you look at this, methamphetamine is still, this would be methamphetamine or crack or crank, hydrocodone, oxycodone. Oxycodone seems to be the one that we're still having lots of problems with kids, and they seem to want to blame that on they get in their mom or dad's medicine cabinet, they've had some surgery or something, and they get attached there. So You want to be careful with that where you store them at home. In Oklahoma now, there is no medical reason, there's not a medical necessity for you to get Lortabs and Xanax or Lortabs and any benzo. And so if that happens, that's one of those things, all kinds of bells and whistles go off and you have to call the OMBDD, and that's never fun. Fentanyl, are you guys familiar with fentanyl? Here's what I had no idea this happened, but they cut those things in strips and they call it chiclets. And then they put the strip with the adhesive in their mouth and they stick it to their bottom gum and they chew it all night. And supposedly, it's a controlled high. I had no idea. But that's some pretty good thinking there. And then morphine with hospices. We're seeing more and more morphine, big doses too. Diazepam, since COVID-19 COVID has been an issue in the last last year, you can't get injectable diazepam for seizures. So we're having to use lorazepam. But, I don't think my doctor, if I say I want a 10 cc vial of diazepam, was going to say, oh, here, let me give that to you. I think he'd want to know a few things first. But anyway, that you can't get anymore because they've used their quota up. If you look at the things from the Oklahoma 1999 to 2011, we're going up and the deaths are increasing in the motor vehicle accidents too. Oklahoma also has, if you have an accident or you're killed in a motor vehicle accident, when you go back, they're going to draw blood to see what's in, whether you have Lortab or whether you have benzos in your blood. Again, since the medications are considered the residents, if you take the medications, you're financially abusing resident. I think the major reason that some of these things happen is, the residents that we could easily take them from have dementia, Alzheimer's, psychosis, schizophrenia, bipolar, mental retardation, where they don't actually know or they don't make good witnesses. In a nursing home, it's just unbelievable the amount of scheduled medications you have. I'll tell you this, we had a home that had a couple of med cards, and they had one of them that was just mostly their evening meds that they gave, and most of it was narcotics. We got a call one night, somebody backed the truck up to their door, broke the door, grabbed the cart, put it in the back of a truck and went down the road. And we replaced the meds. That wasn't a big deal, but those carts are expensive. It was about $8,000. So I was really upset about the car because we went down the road after, when we got there, we said, well, we'll go see what we can find. And, they pulled the drawer out and just tossed it over to the side. And so I was a little upset about that. But anyway, you can't ever be too sure. And then we had the very nicest CMA that I'd ever really went on a med pass with. And we caught her taking urgent patches, and she took them after the shift, walked around the building and gave them to her boyfriend, who rode off into the wind on a motorcycle. Now, I'm not saying if you ride a motorcycle, you use fentanyl. It was just really disheartening. Why divert drugs? I think a lot of times, especially when they're non-scheduled, we're just trying to take care of a family member that's sick. we're taking the antibiotic and we're hoping we're getting the right one because, you know, if something's going around, here's how we're treating it in the nursing home. They're probably treating it in the town the same way. So we do a little bit of that, but they're easily accessible. They're real easy to identify and they're easy to conceal. And you can obtain them on the internet and a high financial yield. And farm parties, are you guys familiar with those? Back in the 60s, when we had antipsychotics, the kids would bring their mom and dad's medicine, pour it in a bowl, and then everybody would take a few. Now, I didn't understand that, but these, it has to be a scheduled medication. They dump them in a bowl and then they take these. And this is why we see some of the overdoses, because some people have never taken a narcotic before. There's a lot of money in diverting medication, and there's a lot of money in Adderall. These kids are getting Adderall and not taking it and then selling it. And you guys have any idea what a 20 milligram Adderall goes for? $6 a tab. So if you get a script, you know, I might have to take off my shoe here, but if you get a script for 60 of them, you know, $360. Also, if you're taking pharmaceuticals, it's not perceived as bad as if you were taking street drugs or anything like that. And a lot of it has to do with financial problems or money. Here's some Opana. When I was in pharmacy school, we didn't, you know, if you had an Opana and it was 20 milligram, it was going to be $10. That's what they were selling them for. I mean, every drug had a price, but it wasn't by the milligram strength. And I think, you know, you got to give the folks in this generation some credit because, you know, they're selling the Opana for $1 a milligram. And if you got 40 milligrams, you get $40, where we would have sold it for 20. Hydrocodone, they cost you about 50 cents, and you're looking at $3 to $5. Do you guys know what bars are? Have you ever heard of that? Bars are, I didn't know. They're square, they're elongated, they're square. You can break them in half, and it's 1 milligram. You break them in half. There's a half a milligram on each side. You can break them in thirds, and there's 0.25 or 0.5, or yeah. And then you can break it so you get each dose separately. Those are a little more expensive than the $5 range. Now here, methadone, and OxyContin, they cost around $9, and you get $1 per milligram. And Oxy is one of those drugs that's on the street that we have a really tough time with. All right, now I'll tell you, I do some stuff for Tulsa County, and anyway, Tulsa County, if you come in and you say, you know, I'm taking oxycodone, we're going to give you Clonidine. I mean, we're not going to give you anything that's any good. You're going to sweat it out for 3 days. But we had all these people coming in to do this, and then they were asking me to sign out that they had 3 days worth of sobriety. And I was, and so, you know, about after the third one, I said, well, what's going on here? And the little girl said, and she was probably 16, 18, I don't know. But she said, once I have 3 days worth of sobriety, I can go down and get methadone. And I didn't know it was that easy. If you look at this is the kind of things you want to watch for. If they carry the trash out a lot without being asked, they come in early, stay late, work on their days off, or in the med room, or if they're ordering, nobody orders the meds and checks them in, 2 different people. Works for free. I've never had that happen, but volunteers for narcotic town. I've had that. And all the time, it's he or she is my best employee and a decline in physical appearance. And those 44-ounce Sonic cups, we don't let those in the med room. They can haul out a ton of stuff in one of those. If you look at indicators of the drug diverter, deteriorating job performance, decreased responsibilities, forgetfulness and routine duties, cuts corners, declining quality, and documentation and ineffective use of work time. Psychological indicators, she's irritable, unpredictable, mood swings, isolation, inability to get along, challenges, policies and procedures, negative feedback, defensive when questioned about errors or poor patient care. That sounds like most of the people I work with. Indicators, let's see if we do that. Once they start to get in where they're having to take the drug every day, I'd say those things that we just went over, if they're still not taking it every day, they'll develop those symptoms. If they are taking it every day, they're always sick, they have cold symptoms, they're late, they fell asleep at work, phone calls, texts. And the other thing you want to be careful about is who shows up to see them. I mean, you'd be surprised. These guys drive up on, again, nothing against Harleys or anything like that. They drive up, in the leather things and no shirt and a vest on, and they want to see your med aid. That's probably not a good sign. Changes in circumstances, living above their means, frequent smoke breaks, personality traits, and you'll have listen to your gut when that happens. And you can do a drug test. That's the easiest way to find out. If you are doing drug tests, make sure you ask them to check for the synthetic opioids, because if you don't, they won't check for Lortab. And, we miss a whole lot because of that. Street language and some slang, oxys, are just oxycontins, stop signs, footballs, those are Xanax, Xannies, these are bars. Morpho, Roxys, and the blue ones are the new oxycodone Percocet or Perc. So I know we got a bunch of those in the pharmacy the other day, and they got to be a lot less expensive than the regular one. Know what your policy and procedures say about diversion. Be involved in all the departments. Check your counters quickly, maybe pull 3 or 4, like I said, and then maybe once a month go through your whole counter with somebody. I think that just them knowing that you might do that might be enough to keep them from diversion. Be involved in all the departments. You need to know what a chart is and how they chart on an MAR and a TAR and a behavior sheet. We had an LPN that worked in one of the facilities, and she had, honest to Pete, I've never seen better pain management charting than what she was doing. But there was a couple problems. She wasn't supposed to be doing it. Only an RN can evaluate pain management. And nobody else gave them but her to these when she was on duty. So we went to the administrator, and the administrator said, "Oh, it can't be her. It can't be her. She does the best charting," and she did. I mean, I don't know if it was perfect. It seemed like she hit all the points you were supposed to. We caught her with a pocket full of OxyContin and Xanax from a man pass that she had just left. And she hadn't given those, she'd been doing that for probably a year. And so then you just, you have to estimate how many she took. And the Board of Pharmacy, if I take 5 Adderall, that's 5 counts. And of course, they plead that down, to 1 count or something like that. But that's the way the Board of Pharmacy and the DAs are doing it now. Okay, be aware of allowing few people too much control. Again, evening shift orders, day shift checks in, and it's probably a good idea to have both those folks be able to talk to the pharmacy to see where they're at on that sort of stuff. And we rotate duties and home call, what's today, Thursday, Monday, and they rotated duties because we talked kind of about that. And we hadn't told the day shift how to order meds on the evening shift. So if you're going to rotate duties, make sure you tell them how to order meds or how to check them in. If you look at those, all your controlled drugs are going to come with a separate sheet. You have to sign those off there when they deliver them. Another couple things, loperamide or Imodium is kind of close to heroin if you take like 80 of them, and they might be getting meds for family members. I think we've discussed that. The easiest points of diversion are from pharmacy to nursing home, order but not claimed, not received. Used to, if you would call us and say, hey, I didn't get Ativan 1 milligram for hallucinating, we just fill it and send it out again. Since the new rules with the DEA and the ONBDD, we don't do that. We have to fill out paperwork, send it to you, and we'll send it out again, but it'll be with some paperwork. Nursing home medication, and this is like if you've got a PRN med, say you've got a PRN Lortab for headache or something like that, and we haven't taken it for 6 months, let's get rid of it, because if you leave it in the cart, it'll disappear. And they'll take the count sheet and the card. So, and if they're smart, they'll take the card that you're counting or the piece of paper you're counting from. Another thing is if you send 90 and you get 3 cards and you don't put a count sheet on each one, you can just have one, they just pull one and you'd be out 30. A patient that has died or drug discontinued and documented as destroyed. No large persons, coats, etc. in the medication room. Large strength styrofoam cups. Your patients. If you have to report to the nursing board and evaluate your policies for your hospice companies, and I think they need the meds, but they bring a lot of narcotics in. Drug testing, have a policy and procedure. I think we've kind of covered that. There's something new coming out too, like this K2 Spice, DMX, and other drugs like that they're making. They're making those so when K2 is declared illegal by the state of Oklahoma, they just, they tweak it a little bit, maybe add a potassium or water. They get the same effect, but it's not the same drug. Background checks, we all have to run those. Training employees, make sure they know where the policy and procedure is, responsibilities, limitations, consequences. We don't have a choice but to turn them in. And so once you do that, there's a possibility you could never work where anybody receives federal funding. Out-of-state pharmacies, they're kind of their own bird. As long as they had a EI, PPS on their packages and things, that's kind of the gold standard I look for. Dangers in pharmacy, counterfeit, contaminated, subpotent. This says out of the drugs that they pull from the non-VIPPS online pharmacies, 95.79% were not recommended to take because of some sort of adulteration. Here's websites you can check out. And we were going to do, I have a couple of COVID tests. If you guys want to see, are you all familiar with those? And I've got one that's serological. If you wanted to see that, we can do that. Are there any questions? I know that's a lot of stuff.